one of the comments that I've heard recently is it's not necessarily pertaining to our practice because we're very cautious about making sure we answer the phone, but many practices have given up on answering the phone for patient phone calls. Number one, phone calls are generally non-revenue generating. Number two, the staff that would ordinarily field phone calls are caught up in the mire of obtaining these prior authorizations, or they are attempting to collect on claims where payment has been denied. That's why, quite often, the phone just doesn't get answered.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Rowe Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello, and welcome to UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Rowe Urquhart, and thank you for joining me for Season 2 of our podcast. Today, I want to reflect on the concept of the other, specifically as we look at the loss of the community doctor and the issues that face those of us that are in private practice in local communities that are thriving or surviving. And we begin to assess the way in which those of us who are doing this work are fighting for our survival. The question was posed to me in a conversation recently. Well, who exactly is the enemy? And when I began to describe the fact that patients are paying more and more of the cost of their care, either through increased annual deductibles, which we talked about last season, increased copay amounts, or challenges in managing coinsurance, that particular aspect or facet has nothing to do with the provider. And looking at from the provider perspective, there are many issues that the providers face. And so I decided to ask ChatGPT, well, who's the enemy? And the way in which I did that was I asked ChatGPT because I had my own list of issues that providers face just from our experience in our private practice and in communication with my colleagues. But I asked GPT, what are some of the strategies that insurance companies utilize to avoid paying providers of healthcare? And ChatGPT gave me quite an interesting little list. And this list makes me think, yes, in fact, if we had to identify in this healthcare triangle who exactly the adversary might be, the adversary is not the patient. The adversary is not the provider. The adversary is the insurance. And this is why. If we look at ChatGPT's answers, one of the primary reasons that smaller healthcare organizations have challenges with insurance companies has to do with this multi-pronged strategy that creates an administrative overload and as a result allows insurance companies to pay less and less of their part of healthcare. Insurance companies will do things such as ChatGPT is telling me this, which I already knew. They'll do something called downcoding. So if we do work, that work is not elaborated in any sort of verbal communication, but rather it is represented by a code. We talked about this previously as well in season one. A CPT code, or current procedural terminology code. And what insurers have learned to do is they've learned to reject certain codes. So in orthopedic surgery, what we do is very specific. And we've had this experience in our practice. There are some complex cases that you may do once every 5 years because patients just don't have this type of trauma in general. Well, what the insurer will do is say, because of the infrequency of the code, we don't accept this code. And I guess I'm actually being understanding or trying to create a rationale. But if a code exists in the book, then why would the insurer not have a mechanism for processing that code? They would like to have the provider downcode or accept a lesser payment for a code of lesser complexity than actually pay for the work that was done. So downcoding is a strategy that insurers use as the adversary in this healthcare relationship. The other strategy that they have employed throughout all specialties is the requirement for prior authorization. And what they will quite often do is flag either a practice or a CPT code or certain types of documentation. They will require increased documentation if they're seeing that a particular surgery is being performed with increased frequency. But the mechanism by which they require this prior authorization is very fraught with hills and valleys that make it sometimes almost impossible to obtain that prior authorization. One of the challenges that we have experienced is the challenge of taking care of patients who have insurances where they are notorious for requiring prior authorization and equally notorious for having reviewers that will refuse to provide that authorization for patients to receive the necessary care. Now this one really gets me. We're moving on to the patient having had the prior authorization, having had the procedure and the care, and having recovered from the episode of care. In orthopedic surgery in particular, we take care of healthy patients with functional limitations. And so they might have an injury, say an ACL tear, a rotator cuff tear, that requires surgery. They can do therapy and recover from that and go on with their lives. Amazing. That's one of the beautiful positive aspects of taking care of orthopedic injuries. But what the insurance companies will do is they will do something called a retrospective audit. And what does that mean? That means that the patient presents with an injury that is covered by insurance. The provider takes care of the patient, accepts what the insurance pays for that episode of care, and the patient recovers and goes on their way. And then, say, 1 year later, 3 years later, the insurance company will do what's called a retrospective audit, and they will recoup the value of the care. And this audit, some of these audits are unfounded. There is a healthcare system that is now in bankruptcy, but there was a period of time where they were recouping payments for surgeries that were done. The patient did well. We went through all of the hoops of providing the documentation as was required in order to get reimbursed for the care that was provided. And then 3 years later, they came back and they gave us a list of about 6 or 8 patients and said, we're recouping the payments for all of these patients. If that's not adversarial, I don't know what is. And they're just banking on the administrative burden and overload to the practice that the provider will just accept this and walk away. Payment processing time. So, this is a strategy that ChatGPT again identified that insurers are using against providers and by extension against patients. And we've certainly experienced this. Customarily, I would say about 3 or 4 years ago, insurance companies would pay within the 60 to 90-day time frame. We would get what's called an explanation of benefits or an EOB, detailing that they received the bill for the service that was provided. They went through their processing and they determined that the amount they would pay was X, a certain amount. So 60 to 90 days of accounts receivable for any provider. The extended payment processing times currently are anywhere from 90 days to 6 months. We have payments that where we've submitted processing and information and we haven't received an EOB and we're going on a year, 1 year. So you can imagine what kind of business can operate where you're doing the work, paying your staff, expending whatever resources you have to provide care, and then you're not even getting a decision on the care that you provided within a reasonable time frame. Extended payment processing. And again, that layers the administrative burden because we are submitting multiple claims for the same point of care. But we have to be very cautious with that because if we submit multiple claims, that could also be a flag that we've submitted a duplicate claim and then that would be rejected. Patient cost sharing, we discussed that. And high volume scrutiny. So, we happen to be in our practice in an area where my husband and partner does orthopedic surgery trauma call. He takes that trauma call at least 1 day a week, and he sees a high volume of fracture cases, be it ankle fractures, femur fractures, tibia fractures, a lot of complex cases due to trauma, motor vehicle accidents, and many other types of trauma. Because of the complexity of those cases, the insurers are raising the red flag. And they are, as I mentioned earlier, either asking us to downcode, to change the code. ChatGPT describes it this way. Insurers may scrutinize providers with high volumes, often seen in resource limited areas where patient demand is high. Insurers sometimes assume high billing means excessive or unnecessary services, leading to audits or claim denials. And that does not benefit the patient. You have patients with complex issues, needing complex care, and the red flag, instead of just recognizing this is a service location where there is increased complexity, they're placing the burden on the provider to prove that this complexity is in fact an organic entity and not a unscrupulous care pattern. Wow. We're looking again at that triangle, this stakeholder triangle in the community doctor scenario. Again, the patient beginning to shoulder much of the burden of the cost of care through cost sharing. You have the provider who wants to care for the patients in the way in which they deserve to be cared for. And then you have the insurer, which has devised multiple strategies to minimize reimbursements to providers and impacting under resourced or high volume complexity of care points of service disproportionately. And that describes, I think, the adversary in this triangle. And I would go even further. one of the comments that I've heard recently is it's not necessarily pertaining to our practice because we're very cautious about making sure we answer the phone. But many practices have given up on answering the phone for patient phone calls. Number one, phone calls are generally non revenue generating. Number two, the staff that would ordinarily field phone calls are caught up in the mire of obtaining these prior authorizations, or they are attempting to collect on claims where payment has been denied. That's why, quite often, the phone just doesn't get answered because you know what the insurance companies will generally do? These private insurance companies who have access to tremendous technology, they will refuse to receive inquiries in any format other than telephone communication, meaning we do not have a streamlined mechanism of following up on claims that is electronic. Our staff are waiting on hold for quite a long time until, and I'm talking 20 minutes, 30 minutes, 45 minutes, until they actually get a live person. And then they have to wait on hold for that person to go back and check the documentation, check their files. And sometimes we get an accurate answer, and sometimes we have to call back and try to get a representative. And one of the first things we teach our staff is when you do get an answer to your phone call, request someone who is onshore, meaning we do not want to speak with someone in an international location who does not have access to up to date information. So the insurance companies, again, the adversary to this patient care triangle, utilizes every possible means to avoid answering the question of can you authorize this care for our patient, or why have we not received payment for care, or why has the payment for care been recouped 3 years later when we're then having to go back to the records and try to find information the patient may or may not be available to our practice to support our claim and rebuttal of the recoupment. Amazing. Unfortunately, in our culture and our society currently, because the premiums are paid by employers primarily, and because the patients are paying their copay, their deductible, they think the insurance companies are their advocates, their support. They're the ones who are helping in a time of need. But the reality is, the insurance companies, as we talked about in season one, they care most about returning value to their shareholders. Patient care is not the primary goal. And paying providers is definitely not the primary goal. Providers are blamed for issues that have nothing to do with the provision of care. The economics of healthcare at this point are looking very bleak and very dire. And more community doctors are just stepping away. If they're near retirement age, they're retiring. If they are not, but this is just such an overwhelming scenario to be involved in, they may join a larger healthcare group. And those patients that are in these under resourced communities are left without the care that they had come to know in their parents' generation. They're left without the advocate, and the adversary has won yet again. We're talking about a $1 trillion industry. And I encourage you to look at the share price, excuse me, of these major insurance companies and track it. You'll see that it's continuing to increase. Look at United Healthcare, look at Cigna, look at Aetna, look at Blue Cross Blue Shield. Track it. You can go online to Google and ask for the trends in their share price, and you will see that these companies are making money. and their shareholders are receiving a return on value. However, our healthcare systems are providing care. They're paying for the cost of the implants, the instrumentation, the injections, all of those things, and they are not being paid. That is what the adversary is capitalizing on in our current healthcare system. Let's check back with one another in 2 or 3 years and see if we have many community doctors left. Sorry to be so bleak, but we need to talk about the problem as we're going to continue to explore solutions. Thank you so much for joining me for another episode of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.